Anything about Kawasaki, but you already refreshed my memory. I don't know anything about Kawasaki. So PMR treatment respond rapidly. Remember, I told you they respond rapidly to low dose prednisone. And for Takayasu is the patients have severe hypertension, claudication, or vascular insufficiency symptoms. So to summarize, when you're confronted with a patient with joint pain, the first question you need to do is get a very good history, duration of symptoms, do a good exam. If you see synovitis, you actually, if you don't see it, you actually examine the patient. If they have multiple tender points, you think about fibromyalgia. Are you guys familiar with the fibromyalgia exam? Like patients have like 14 points that are painful, like posterior neck, here, shoulders. Just take a look at the picture. And this is very common. It's actually a very common cause of like chronic pain. You do not treat fibromyalgia with steroids. Don't fall into that game. If you have a patient coming in for chronic total body pain with no evidence of inflammation or anything, don't give him narcotics. You guys have worked very hard to get to this point, and you're going to be getting a license. And sometimes you guys feel, if you're working in the ER, urgent care, you feel like an easy way to get rid of someone is just like, okay, what do you need? I'm going to tell you two things. I'm going to tell you that now it is required by the law in California that you do a cures database search for every patient that you're going to be prescribing an opiate. It's required. So because there's a lot of doctor shopping, there's a lot of like opiate abuse, and the patients with pain-seeking behaviors, they become very sophisticated. They go to different providers, different ERs. They come up like very late, like when you're about to finish your shift. They know you're exhausted. You want to get the hell out of there, and they just want to tell you like, oh, I have dental pain. Dental pain is the perfect excuse to get an opiate because it's painful and because there's no way that you can actually rule it out on physical exam. But how are you going to rule out if somebody has dental pain? You can't, right? Yeah, you can't even do a good exam, and then if they go, oh, I have terrible pain, if you can give me something until I see my dentist next week. So, and they know what they want. So that's one thing. Number two, you're required to check at the database. Number three, if you didn't know this, for the first time in the history of this country, a physician was convicted from prescribing narcotics to kids. This doctor was in Lancaster. She was prescribing, she had like horrible behavior of like prescribing practices. She became popular even among kids like driving from out of state. These kids were coming from Arizona to get opiates from her, and she had a sliding scale. If you want Norco, it's this much. If you want oxycodone, it's this much. If you want fentanyl, it's this much. The lady ended up killing 2 kids from opiate overdose. So her license was revoked, and she was sentenced like to 40 years in prison from doing that. So you guys are liable. So when you prescribe pain for chronic conditions, you're doing a disservice to the patients. If you're prescribing opiates for fibromyalgia, you're wrong. You need to go to school, and you need to, you can't defend that in court, number one. If you're prescribing opiates for chronic headaches, you're very wrong. You can't prescribe it for, and if you're prescribing the equivalent of more than 100 milligrams of morphine, there's like conversion tables that are available. You can just Google it. There is no reason. Even if a patient has tolerance, you guys know that one of the features of opiates is that you develop tolerance, right? So tolerance means that you need a higher dose to achieve the same effect over time. And a lot of the pain patients, they end up developing tolerance. What research shows is that most people that die from opiate overdose, this is a serious problem. Like, I don't know if you guys saw in the news that in one town in the Midwest, like 9 people died from overdose the same evening. 9 people in a town. So EMS was like going crazy, like what is going on with these people? They're either using heroin or they're just getting a lot of opiates from the physicians. So what I'm trying to say is that your patient, if your patient is requiring more than 100 milligrams of opiates, no matter what the patient tells you, you cannot prescribe more than 100 milligrams. Because from extensive research, we know that the risk of dying from opiate overdose significantly goes higher and higher after you cross that threshold. So my advice is that if you have chronic pain, there is a specialty called pain management. Get rid of them. If you start practicing this kind of medicine that you give opiates to everyone, you're going to be in trouble because you can't stop these people from coming to you. And if you guys remember, opiates are only FDA approved for management of acute post-operative pain or management of cancer patients. That's it. We physicians prescribe them for almost anything. But if you were going to look at the textbook definition or the FDA definition, those are the two only indications to prescribe opiates. But I don't want to discourage you guys, but fibromyalgia is common, and you're going to see this a lot, like patients requesting opiates for management, and that's wrong. This is a very complex disease. We don't know what causes it. Patients require like multidisciplinary approach. You need to make sure that you restore the sleep cycle, because there's a lot of like physiopathology involving like sleep deprivation in the development of this syndrome. You need to refer these patients to physical medicine or physical therapy because they need a lot. They need to have an exercise program, and you need to treat them with non-opiate medicines, including like some of the like gabapentin or Lyrica, and there's like actually new medications that are FDA approved. They're very expensive medicines. So my advice is that if you establish a diagnosis, you need to understand that if you're going to be primary care on these patients, you need to get a bunch of players involved in the management of these patients, because it's a very challenging condition, and the patients, they have very low threshold, very low tolerance for pain, and they don't get better. It's very frustrating. That's why I was just sharing with you guys that my friend, she tells me like, I have a fibromyalgia service instead of having a rheumatology service. It's very sad. Okay, so tender points, multiple tender points, fibromyalgia. And if they don't have tender points, you think about viral. Remember, we talked about parvovirus and hepatitis C. You have osteoarthritis, soft tissue abnormalities, hypothyroidism, neuropathic pain, metabolic bone disease, depression. Depression and fibromyalgia goes hand to hand. And the testing that you can do for those patients that they don't have synovitis and they don't have tender points include like you doing LFTs just to rule out hepatitis, hepatitis B and C serologies, X-rays to look for erosion, like I said, or any structural abnormalities, TSH, calcium albumin, and alkaline phosphatase. Alkaline phosphatase can actually be high in bone disease as well. There's a test called the bone-specific alkaline phosphatase that you can order for those patients that you suspect that they're actually having primary bone disease. So the other big category, if you see synovitis, you need to classify them based on duration of symptoms. That's why I was asking you guys, get a good history. So if it's less than 6 weeks, you think about viral or early systemic rheumatologic disease. You just do a careful follow-up. You may or may not check the serologies. If they're negative, you can keep observing these patients because they may have like an early systemic rheumatic disease. If they're positive, it's a self-limited disease. It usually goes away with a little bit of NSAIDs. But if they have systemic rheumatic disease and you confirm the diagnosis, then at that point I probably would suggest that you guys refer to rheumatology, because these patients, they need to be managed by a specialist. So this last slide, I got it from UpToDate. It's a very useful slide. So when you're in practice, save it. When you're in clinical practice, when you're in urgent care, just remember this, because it's very helpful. It's a very helpful workflow for you to understand, like, what am I dealing here with? Okay?
How soon would the CCP show up after?
Very early. I mean, it's just the pathogenic antibodies, like an IgM type of antibody is positive in the early course of the disease. But most people actually, we try not to do testing because it may be a viral thing. So most patients actually get the testing like after 6 weeks. But remember, I told you how important it was to recognize and treat early, because you can leave patients with permanent joint damage. Okay, so let's do at least one. Oh shoot, it's 7 p.m. already. So I'm gonna talk briefly about the cases that I gave you. So if you take a look at, so I want to be able to cover nephrology at least. Yesterday when you weren't here, are you guys here? Both the three of you are here on Thursday? Because Ramiro told me not to come tomorrow, just to come on Thursday. Yeah, nephrology is so important. I really want to cover those two cases. They're very educational. What else do you guys want to cover?
Like
Pulmonary, okay. You want to do derm?
Nephrology is just one of my weak points, so
Okay.
I love it. I actually
Nephrology. So I want to spend time, because if I rush it, you're not going to get all the benefit, because this is They're very broad cases. I do it with the UCLA med students, these cases, and we go one by one. I included a copy with the answers, but I want you guys to do the exercise at least to think about the different things. Do you guys want also like urgent care knowledge? Like a little bit of
Always good.
Okay, so let me see. I think I have a dermatology talk too.
Okay.
Or like urgent care pathology, like ENT, all that stuff.
The
So
ENT
all the
would be-
PowerPoints that we can get from
Yeah, yeah.
Romero?
Absolutely. Yeah. He has them all. I keep sending them. I don't know if he's distributing with you guys. But
ENT would be really good.
yeah, why don't we meet? Yeah, why don't we meet on Thursday? We do it, you know, we spend at least 1 hour, those two cases, and then the other hour we do like urgent care kind of stuff. Yeah, so again, all that useful information I'm giving you, like the opiates, I'm telling you, people get in trouble for doing this. The other day I was in the urgent care and a guy came asking me for an opiate. For tramadol specifically. I went ahead and I looked at the cures database. He got 12 prescriptions. And this is a Kaiser member. Like I would think that he doesn't go to other urgent cares or other providers. He was getting it even from doctors outside Kaiser. That means that he was probably paying. There's a bunch of like urgent care clinics. Patients go and they pay $40 and they get a prescription for that. So you're required by law to check it. And it's on you. If you don't check it, it's on you. I mean, it doesn't mean pharmacy is not going to dispense it, but you're required to check it. So think about prescription practices. Like I talked to you guys about pain management. No NSAIDs in the elderly, history of GI bleed, history of chronic kidney disease, history of heart failure. You cannot prescribe NSAIDs on those patients. So just before you prescribe, just think about like, okay, does this person has a contraindication? And use pain management as the specialty. Those guys, I would hate to do that for the rest of my life. I would hate my life, but there's some people that they enjoy doing that. Yeah, but they do a lot of like cool procedures and they try to minimize. Yeah, thank God they exist. It's like palliative medicine. Thank God, because we need doctors, more and more doctors, like joining these fields that are less desirable for most of us, but they do a great work, like helping people.
Yeah. A follow-up question from yesterday.
Yes.
For hypertension. So like in the urgent care setting, or maybe even primary care setting, and you have a patient who is like has a systolic of maybe like 170s, like but it's asymptomatic, so no end organ damage. Like, do you usually treat them, or like do you usually give a clonidine, or do you just go ahead and like start them slowly on like monotherapy?
For medical legal reasons, you want to document that there's no end organ damage, that you did like a quick fundoscopic exam, the patient doesn't have any symptoms, you know, did an EKG, like that. In that setting, if the patient has no symptoms, I start them on something. If you don't have labs, amlodipine is the drug of choice. Remember, the same category. If you have recent labs, you can prescribe a thiazide diuretic.
Okay.
But remember that every time you prescribe a thiazide, you are required to check chemistry a week after, because of risk of hyponatremia. So, and other metabolic things, but probably hyponatremia is the most dangerous side effect from the thiazides.
Okay.
But I usually start in 170 is probably just diagnostic. But remember, like for the boards, they want 2 readings. They want like separate days.
I was more
like more in the real world. In the real world,
you worry about touching that and bringing it down more, or like it's like 205.
yeah. So that patient probably doesn't even have a hypertensive urgency because it's a blood pressure. But there's no magic number for hypertensive urgency. Remember, we talk about that. Hypertensive emergency definitely depends on the setting. If you're dealing with an ischemic stroke, you allow the patients to have permissive hypertension in the first 24 hours. It's like an inpatient management. But if you're dealing with a dissecting aortic aneurysm, or you're dealing with intracranial bleed, those patients, they need to be normalized with IV beta blockers, preferably. But we use other drugs like nitroprusside or nitroglycerin drips, or even other like beta blocker drips in the ICU setting. That's a clear indication for ICU. So when you're a resident, don't block any of the other residents from bringing a patient in the ICU with a hypertensive emergency, because you can't do a drip in the floor. You need to do it in the ICU. And we always had that struggle at UCLA, like, oh, he's fine. What am I going to do? This patient needs to be like if you want to have permissive hypertension, you can only accomplish that by turning off the drip and giving up a little bit, turning up the drip. So we got a lot of like pushback from the ICU resident because they're so overwhelmed. Like, oh no, just send it to the floor. It's a constant struggle, and you're gonna be part of that struggle. But yeah, a patient, asymptomatic patient with clear hypertension, you can just start him in one agent. I personally wait for 2 weeks before I titrate. Some doctors they do it faster. I personally like to wait because you wanna be logical. You wanna be like the half-life, 5 half-lives at least to achieve full therapeutic effect. There. Okay. Questions? Yeah, room is abstract. For the boards, it's straightforward. If you think about this workflow, you're gonna be fine. They wanna trick you with systemic diseases, associations. They love lupus. You're gonna get at least 2 or 3 questions about lupus, so just study the criteria. They love
I always get like temporal arteritis questions.
temporal arteritis is a board favorite because that can be significant damage if you don't. Yeah, you can go blind. Yeah. Yeah, my advice to you guys: urgent care is a dangerous job. I'm not meaning to scare you from going in the field, but I'm just trying to make you aware of the risk of doing this job, because I've been doing it for a long time, and I've gotten QI like at least 3 times from urgent care cases that I don't think there was any wrongdoing, but it's dangerous because number one, it's very fast paced. You're required to see like 3 to 4 patients per hour. Number 2, there's no relationship with the patients, so you're more likely to get in trouble because they don't know you. If I messed up with one of my clinic patients, it's very unlikely that they're gonna sue me. Like the other day, my pharmacist messed up with one of my patients. He ended up getting a lot of like Solumedrol, like IV steroids. Instead of 1 month, he ended up getting 4 months, and I wasn't aware of that. So when I disclosed it to the patient, he was very upset, but he didn't sue me. Why? Because we have a very good relationship. In the urgent care, there's no bonding. It's boom, boom, boom. And number 3, a lot of the times patients present with pathology that you think that you got it right and you didn't, because we all make mistakes. And patients can have atypical presentation. Like the other day, I saw a patient in the urgent care with a complete heart block, and her complaint was dizziness. And the only reason I did an EKG is because the heart rate was 41, and the patient was in complete heart block. I would have probably sent that patient like, oh, you probably have some vertigo, don't worry about it, here's some meclizine. Patient could have died. But you can see septic patients or hypotensive patients with sepsis or SIRS. If you send a patient like that home, you're in deep trouble. So you gotta be and you need a set of skills to be able to survive it, because the volume is very high. So you need to be an effective communicator. You need to be an effective recognizer of patterns of disease, whether or not this guy is here for a work note. It's funny because when I teach students about this, I tell them like, when nothing makes sense, ask the patient if they need a work note. And if they tell you, yes, I need a work note, then everything makes sense, and you put everything together. Because sometimes patients make things up. Just, they need a work note, and they're ashamed to tell you, like, I was just lazy, I didn't want to go to work, and I need a work note. So, like, then sometimes they make up things that you're killing yourself trying to understand what is wrong with this person, and nothing makes sense. Like, ask them, work, like, yeah, I need a work note. But I'm gonna share with you guys the three times that I got QI. You know what QI is? Quality improvement. So every organization has internal review processes to improve quality. So when the patient actually complains, or when there's an adverse outcome, in every hospital there's a group of people involved in that committee, quality improvement. So my first QI was a patient who came in with classic UTI. The patient had a positive UA, and I prescribed Cipro, which was indicated because the patient ended up having E. coli UTI that was sensitive to Cipro. The problem is that the patient had myasthenia gravis, and you're not supposed to use fluoroquinolone antibiotics with myasthenia because that can exacerbate the muscle weakness. I didn't know that. I asked the chief of medicine when he asked me, like, did you know that? He told me, like, to be honest with that, I didn't know that. I called the pharmacist who dispensed the medicine, and he said, like, I didn't know that. So I wasn't given any bad score. Like, the process is usually a 0 when there was no wrongdoing. 1 is like, don't do that again. 2 is like, you're really messed up. 2 is like, this is bad. And if you get like several 2s, you're out. That's how strict it is, the process. So I got a 0. The other day I got a patient with history of lung cancer coming in with upper respiratory symptoms. My nose was very clear. Patient, other family members with similar symptoms, cough, the shortness of breath. Vital signs were normal. Because of the lung cancer history, I did an x-ray. My read was consistent with the radiologist's read, no acute process. The guy went home 6 hours after he saw me, he died. And the wife was very upset. And she complained, they did a QI. There was no wrongdoing because if I would have gone back, I would have not done anything different. Vital signs were normal, my workup was appropriate, my documentation was appropriate. But I had to go through the headache because you get notified and you need to explain yourself and blah, blah, blah. And they have a peer review process. It's just very unpleasant. You know, you don't need that kind of stress when you're already dealing with so many things going on in your life. That's why I'm telling you, this is Disneyland, dude. Disneyland. And then the third one was a patient in the hospital who actually was going into respiratory failure from severe metabolic acidosis, and one of the other doctors wrote me up because he felt that I didn't give the dialysis to that patient in a fast way, but what he didn't know is that I was giving him a bicarbonate drip. It's exactly the same as giving dialysis. So he didn't know that. He thought like, oh, dialysis is going to fix the metabolic acidosis. It's just the same thing. Dialysis, we do it for severe metabolic acidosis, but we remove fluid. This person didn't need to have any fluid removal. In fact, the patient was volume depleted. So I was doing the equivalent of dialysis. So, you know, at the end of the day, he looked bad because obviously instead of coming to me telling me like, hey, you know what, I think there was a wrong problem, I would have explained to him like, well, by the way, it's the same thing and you can talk to any other nephrology. So, but I'm just telling you that practicing medicine is stressful. You may miss a dissecting aortic aneurysm. Sometimes I get very uncomfortable because I get a bunch of chest pains in the urgent care. It's not the right setting. You know, for ruling out an MI or an ACS, you need to have consecutive troponins. You need to have the patient in a bed with a cardiac monitor, with a chest X-ray. You know, all the workup. And here I'm forced to be seeing patients to rule out ACS. Like, oh, you need to go to the lab. You need to go walk to the lab. You only need one to collapse and die in the way to the lab or in the way to the X-ray room to be able to get in trouble. So that's what I'm telling you. It's nice because it's fast. You become very experienced and you get to do your job in a very efficient way. And once you do this for a while, it's amazing because you walk in the room and sometimes I really, just by looking at the body language or like the chief complaint, I already know, I can actually already know what the patient is going to be telling me. It's funny, I don't know how to explain it. It's like you're having a deja vu when you go in the room after you do this for a while, because it's like you've seen so many humans with the same kind of problems that you can actually predict. But even myself, that I consider myself very seasoned because I've been doing this like since I was 23, I've been doing this and I'm 41, so I've been doing a lot of like urgent care throughout my life. I can still feel that it's a dangerous work environment. It's not scary, but I want you to, if you're good, if you know your stuff, you shouldn't be scared about it. But my advice to you is like be very, very assertive, very pleasant, joke around with the patients, be very, very pleasant with them, try to explain, be an effective communicator, because I do a lot of like coaching for physicians that are just starting. Be an effective communicator with the patient, but know your stuff. Like yesterday we were talking about hypertension management. If you don't have a chemistry, don't start the thiazide, because that's malpractice. You need a thiazide before and after. That's why amlodipine is a very good drug, or clonidine is a very good drug to bring it down in the urgent care. If the patient is coming, oh, my blood pressure is too high, you need to do something about it. Even though you know that 170 is not, you don't need to do anything, but you need to please that patient. You give him a little bit of clonidine, you send him home with amlodipine. It's quick, and you're not gonna get in trouble. But if you don't know this guy, or let's say you have a patient with gout, and oh, you have gout, this is classic gout, and you prescribe an indomethacin, and you didn't have a chemistry, and the patient had advanced kidney disease, you put him on dialysis. For sure, you're gonna put that patient on dialysis if you give him indomethacin. So you gotta be smart. You need to know your limits. I know my limits. I'm very uncomfortable with eye complaints. Like guys, like visual acuity, I'm not seeing. Oh, wait a minute. Oh, do I really need to come? Like, yes, I think you need to come. And you become like, the problem is like you guys are going to be very efficient, but you have a problem that you're going to always have that little fear from the specialist. Like, oh, this guy's going to give me, it's going to give me a hard time. So don't be afraid. You're getting paid. Your license is on the line. If somebody has an eye complaint, you have a dissatisfied patient in front of you, you're not going to risk it. You're going to send this patient home, and what if they like a retinal detachment? Are you qualified to diagnose that stuff? I'm not, and I don't think any urgent care doctor is. But we follow patterns, and that's why we do like all these like structure procedures. Like, okay, I'm going to change visual acuity. Visual acuity is change. Acute, that's all you need to know to be able to get the next step. Like I tell my patients, I don't know how to make bread, but I know who makes bread. You know what I mean? It's like your job is to identify this kind of stuff. Your job in many ways is becoming a very qualified technician. It's like, okay, then this is next. This is next. And after you do this for a while, you become very comfortable. But you gotta know your limits. If a patient is asking you for something unreasonable, like somebody asking you, like for instance, you're in urgent care, and the patient has a pain contract, you can't give them opiates, and you just pull the policies from the urgent care. Most urgent cares have policies like, here, I can't give you any opiates. Or if you really want to just get rid of that patient, like, here, you have 3 days, talk to your primary doctor. You have 3 days, nobody's gonna follow you if you give 10 tablets of whatever, Norco. So think about all the things that you can possibly do to, number one, satisfy the patient, always like patient-centered. You're going to be helping the patient and to be efficient. But like a lot of the things that we talk about, like there's some diseases that can get you in trouble. Most of the things you're going to be seeing in a daily basis is just pretty straightforward, like URIs and things like that. There are few diseases that can get you in trouble, but you live and learn. I think you're never immune to do something wrong. That's what research shows, that we all get sued at one point in our careers, at least once. Most physicians in the United States get sued at least once. That's what research shows. So don't be afraid of it. Just know your stuff, document carefully, be pleasant with your patients, and try to do your best. But it's a great career. I like urgent care. It's fast. It's not boring. And patients go home. You don't have to deal with after visits calls and labs. You take care of everything right there, but sometimes there's things that you can avoid.
How long did it take you to be comfortable?
Probably after 1 year, you're going to be very comfortable. After 1 year of doing this. And my advice, now you guys are starting, like, be friends with the attendings. Ask questions. I don't think no doctor is going to get upset if you get a question from your colleagues about this, about that. Because at the beginning you need guidance. You guys are only doing this for 2 years. Like your PhD school is only 2 years, and your clinical. Whereas an internal medicine guy, let's say an internal medicine doctor, they do this for 4 years in medical school, and then they do 3 years of residency. And for some of us, like me, I went to medical school in another country, so I had to do it twice. I did 2 internships, and had to do this whole process twice. So a lot of the guys that are there have seen a lot of different things. Don't be afraid of asking questions. And when you call a specialist, very respectfully, you can explain to them, like, this is my level of training. I just want your guidance. And I guarantee you that no doctor is going to be a dick to you guys. It's going to be like, I'm very happy when I get a call from a PA from the ER, when I'm on call for nephrology, and I get a call, trust me, I never get upset. I always tell them, like, oh, thank you very much for calling me. This is what I think we should do. And it's great because you guys learn, you're reassured, and you learn the next time, this is what I do, this is what I don't do. And don't be afraid of asking questions, because that's why I always tell, like, new doctors and for you guys, ask questions. Yeah, sometimes you always have that feeling like, oh my gosh, I'm gonna call this specialist. I don't care, I don't give a. I call whoever I need to call, no matter what the time is. That's why you're on a pager, and that's why you're getting paid. If you're gonna get upset at me, good. I'll have that in mind for the next time I interact with you. But call whoever you need to call. If you're never gonna be faulted if you call. you're going to be faulted if you don't call and document. That's all I can tell you. That's the secret of your job, just document. Yeah. Very good. All right, guys. I'll see you then on Thursday, okay? Very good.